Okay. So I'm Amy Cunningham. I'm one of the metabolic nutritionists at Tulane Genetics. Let me get my glasses. I work with Dr. Anderson, and I'm going to sort of pick up where he left off with some of the things he highlighted are also found in the GMDI paper. So I'm not going to talk about those, but those were in there so that those two papers had the ability to stand alone should they need to. There are many people who put the nutrition guideline paper together who also sat in the work group for the ACMG guideline writing, and the decision was made to publish these two back-to-back companion papers, one focusing on medical diagnosis and treatment, as Dr. Anderson's just described, and the other on nutrition management. And we thought that that might make them more useful to different practitioners. Okay. The purpose of the GMDI paper is to update nutrition management recommendations, and this includes especially how to manage incorporation of new therapies into our practices. And you see on this slide the areas that the paper was organized around. And I've put in italics the areas where I think things have sort of changed from our former guidelines or are currently practiced but really needed some public published affirmation so that we can say, yes, this is the way that it is best for it to be done. First, we decided that, or based on evidence and consensus, decided that the DRIs are useful for all nutrients except for phenylalanine, tyrosine, and protein, which of course we're going to manipulate for dietary treatment. And because we're giving this pretty artificial diet, we decided that there needs to be more guidance on best monitoring of micronutrient status, and that supplementation should only happen when there is a need that's shown by either labs or dietary intake evaluation. This is especially important because some of the newer medical foods are not consistently supplemented with vitamins and minerals, and so a choice of medical food can have a variety of adequate supplementation. And also you have to consider how much of that medical food is really being taken in. This is a picture of the monitoring table. Again, I would encourage you to access both of these articles and look carefully at the information that's in it. There was a great deal of effort that went into this table too. It's famous, so I would hope that maybe you'll find it useful. This is the table that shows intake recommendations, which haven't changed all that much. Again, in italics, these are things that you will see over and over again, and I want you to notice how much you see the word individualize. That was really a focus of this paper, so it's repeated often. And this is a recognition that treatment isn't a one-size-fits-all affair, that it really needs to fit an individual patient, that patient's needs and ability and skills to comply with what we're asking them to do. We all do that, but this is official recognition that that's really important. We also did a recommendation about breast milk. We all are comfortable using breast milk combined with metabolic formula for infants, but this is just a validation of that practice. Choice of medical foods to best fit the individual, and consideration of other therapies, how to fit those individual therapies into treatment. This is another table that's in the paper that summarizes medical foods and hopefully is a useful list of where to start in choosing medical food that's important for a particular patient. We spent some time looking at pregnancy as one of the special populations that we treat, attending to the needs of those special populations. We want to encourage treatment continuation through the postpartum period. This is a lost period for many patients. Something like 70 to 90% of patients go off a diet in the delivery room, basically. And there are lots of benefits to be gained for both the mother and the child if that doesn't happen. So we wanted to encourage that based on the literature that we read. Also, more monitoring of other nutrients besides Phe in pregnancy to be sure that there's adequate protein and calorie intake, because this is really important for not only the mother but the outcome of the fetus. And a recommendation for another population of people to not lose those hyperphes. You know, it used to be that if you had a level of 10, you were called a hyperphe and you were sort of dismissed and not followed. And we know in light of the benefits of a tighter control range and new therapies that are available, that those patients could be getting some benefit from genetics care, and many of them are lost to follow-up. So just a quick summary. The recommendations call for, again, individualization. I can't say that too much. That really was a focus and a way to look at patients other than just based on Phe levels. We hope that these papers, both papers, encourage people to think about new practice guidance and new treatment options, and to be open to including those in their practice when they see that they can benefit their patients. We encourage better monitoring of nutritional status. All of us sort of do that, but we don't really sometimes have a clear idea of when and how best to do it. And as Dr. Anderson said, a documentation of some of the things that we currently do, but that we really need affirmation so that we can have better obtaining of those resources for our patients. I just want to say one more word. There are in-depth guidelines that are being developed by GMDI and SERGG with the support of HRSA and the National PKU Alliance. And these are extensive evidence and consensus-based with practice tools included in them. They're almost done. They're going to be posted on the GMDI SERGG websites at the end of the year. So this will be the final piece to this updating PKU guidance and treatment. Okay. Questions for me or for Dr. Anderson before we call our panel up? Okay.
So I'm now going to introduce and invite up to the panel table up here 4 of our collaborators here. So Sareka Pendyal, who is a metabolic nutritionist at UNC, is going to speak for a few minutes about individualized therapy. Dr. Nina Champagne, who's a clinical geneticist from Greenwood Genetics Center, will talk about psychological, neuropsychological, and genetic testing. Helen McCune, who's a metabolic nutritionist from the University of Gainesville, will talk briefly about management of phenylalanine deficiency patients who have the least amount of tolerance, so the most difficult patients. And then Pam Arn, who is a geneticist from Nemours locally, will speak about transitioning. So maybe we'll start with Sareka. Would you give us 3 to 5 minutes about your topic?
Sure, okay. So the treatment of PKU has come a long way over the last 20 years. And conventional treatment with just diet therapy and formula is difficult to comply. So now some adjunct therapies have been introduced, and it's very important to individualize. So individualizing the diet itself is also possible, and we routinely do that at UNC in terms of just the Phe tolerance. Even if you start a child with a certain amount of phenylalanine, it's really important to monitor the Phe levels in the diet and to keep challenging if the blood levels are being maintained in the treatment range, to continue to increase the phenylalanine, so in order to give the child the most amount of natural protein you can and improve the quality of the diet. So this is like a Phe challenge we do. Again, individualizing just the diet itself now, dietitians in Europe are using a different approach to the PKU diet in terms of liberalizing the intake of vegetables and fruits because they're just so limited in their phenylalanine tolerance. And that is something that also can be done, especially in the children who or individuals who have somewhat of a higher phenylalanine tolerance. And that can also help in increasing the quality of the diet as well as improving the satiety. Regarding the use of low protein foods, those are expensive, very difficult to 3 to 4 times more expensive than their traditional counterparts that you buy in the grocery store. So there's not much that you can do about them, but there are some low protein versions that you can buy in the grocery store, and certainly you can provide your families with that list, like the gluten-free options that can help in making the diet a little bit more satisfying. The use of Kuvan is very common. We offer it to all the patients. At UNC, we have tried close to 60 to 70 individuals on Kuvan, and we have had a response rate of about 30%, being able to bring down their blood phenylalanine by at least 30% or come in the control range of 120 to 360, or those who are out of control then have a phenylalanine reduction of 50%. So most of these individuals are in the hyperphe category, although we have had some surprises by having the classical PKUs also respond. My observation with the use of Kuvan is that, it's basically bottom line is compliance. And individuals who have been good with dietary compliance, formula compliance, doing their blood samples regularly and maintaining their blood levels, and are now taking Kuvan are doing extremely well. But individuals who have been out of control prior to the trial of Kuvan, who were not drinking formula, were not sending blood levels, and on top of that have added a Kuvan as an adjunct therapy, are again on the slippery slope. These are the individuals whose diet has been liberalized somewhat because of the use of Kuvan, and now they are liberalizing it further and going back into the having higher blood Phe levels again, all over again. And then that's a concern that they are not also sending blood levels to monitor. Regarding large neutral amino acids, we are using that in individuals who are having difficulty controlling their blood Phe levels. These are mostly older individuals, not children, and certainly not pregnant women. And again, the utility of that is mostly subjective because you don't see an impact of that on the blood phenylalanine level. I just want to finally comment on the impact of the recommendations on our clinical practice. As Dr. Henderson pointed out, the new guidelines are 120 to 360. And previously, we used to recommend these guidelines for children under the age of 8 or 10, whereas now these are to be expected from everybody. So are these possible? These are very difficult to attain. However, we mention it to everybody in clinic with the hope that with these stringent recommendations now, maybe the patients will try further and to do a better job of bringing them down a little bit. One last comment is the impact of the adjunct therapies is just taking, the dietitians are taking a much more role in not just providing diet therapy, but also getting involved in the pharmacotherapy, taking much more time in trying the Kuvan, analyzing diet records, making sure they are being compliant with taking their medications and monitoring their blood levels. I think I'll stop there.
Great, thank you. Maybe Nina Champagne, would you speak to us about the neuropsychological testing and genetic testing?
Certainly. Before I just make my comments, I decided to talk on these issues because this is something that we're able to do quite readily at the Genetic Center. So for those of you who aren't familiar with the Greenwood Genetic Center, we do receive funds from the state of South Carolina for our metabolic treatment program, which allows us to have a full team of not only physicians and dietitians, but also 2 psychologists, as well as laboratory folks who are both trained and certified in both biochem and molecular. So in regards to the genotyping, we pretty much do that uniformly for all of our babies and children. We were able to look in our database, and we had 175 patients, and approximately 50 to 60% have had genotyping, but when we break that down by those that are 10 and under, about 90% have had genotyping. What that does for us, we're able to turn it around quite quickly. Usually within 7 to 10 days, we can get a genotype, which allows us to confirm the diagnosis, and we don't have to reflex to doing cofactor testing for one of the other biopterin defects. I think other benefits in doing the genotyping relate to just allowing for that to be available for other family members if they're interested in knowing their status. Long term, I'm hopeful that it'll be another added piece to our program that we can then do retrospective studies. We do not use it to direct care. As Hans mentioned, we will go ahead and do different trials, Kuvan trials, that are not based on a specific genotype. So we do have that readily available and are doing that uniformly. The second piece that we're fortunate enough to have is psychologists. So they're embedded within our team, and they see our PKU patients as well as other metabolic condition patients fairly regularly. I'd say within the first 3 years, we try to get the psychologist to see them every 6 months. We'll push it out to a year if we don't identify any issues that are of concern that need any type of intervention. As they get older, we space that out to yearly or as needed if there's a change in their course of their treatment, such as large neutral amino acids or Kuvan. We have been adhering to the different tests that were recommended in the practice guidelines, and that's largely in part because our psychologists correspond readily with Susan Weisbrun, who's I think been a leader in kind of defining what instruments should be used. And just to give a couple of case examples of where we find benefit. So I think on a regular basis, it provides reassurance to families that their children are meeting the milestones that they need. If problems are identified, then the psychologist is able to help identify resources or help the schools, teachers identify what areas would be a benefit for these patients. On different levels, we've used it in order to reinforce some of our concerns if a family isn't following the diet and the levels are coming out of control. We have one case, for instance, where despite the fact that the levels were out of control, demonstrating that the child was able to gain 6 months worth of development after going on to a diet with normal levels, and convince Department of Social Services that they needed to be involved. So I think it helps add that layer of understanding for the non-genetic metabolic professional. On the other end, we had an older individual who was not a very compliant patient, and his IQ was just above 70, which meant that he didn't qualify for disability. But with all of the battery of tests that were done, we were able to demonstrate that his executive functioning was just not in an area where he would be able to keep a job. And after 2 appeals, we were able to help him qualify for disability. So those are examples of where I think it becomes a benefit in following them routinely and seeing when their fog is starting to have a problem or create a problem either within the family or the school, that we're able to identify that as soon as it happens.
Thank you, Nina. Helen McCune, would you talk to us about management of the PKU patient with the lowest phenylalanine tolerance?
Okay, which is really, I'm going to sort of talk about adults. So I opened the guidelines, and I'm thinking, I hope our clinic is doing these things. So I wanted to talk a little bit about the goals and monitoring. So I thought, oh, great, the frequency, we're doing fine. The recommendation, we're definitely recommending the Phe levels between 2 and 6 or 120 and 360 to all of our patients except adults. I don't think when adults come to see us, we're saying we want your levels between 2 and 6. And I'm not so sure if I go back and think that I think I probably say that's the ideal treatment range for children. But my approach has been to sort of be a little bit higher. And I think I wish that there was more data to say what the ideal treatment range is for adults so that we can tailor that a little bit better. So if we have adults that have a really low tolerance, to keep their levels between 120 and 360 means they're going to eat very little natural protein. They're going to have to use a lot of low-protein foods, which has cost and preparation attached with it, and many of the adults aren't interested in cooking, unfortunately. And then to meet their needs, they're going to have to use a lot of medical food, which is expensive, and these are patients that are underinsured or have no insurance. So what have I done? What have we done in clinic? I think when I see adults that have liberalized their diet or are off diet and come back to us, you know, I'm sort of willing to take them wherever they can go. So I definitely will say that I'd like them as close to 10 as possible or under 10. And if a woman, I remember one woman came in with levels of 30 milligrams per cent, and when she was under 20, I was thrilled. And I have another woman, and I'm thinking that maybe this is the kind of thing maybe we could do. I have another woman that titrates her use of low-protein food based on her anxiety and symptoms. And so when she's more anxious and she can't sleep, she knows the next day she needs to really cut back on starches and use more low-protein products. I've never quite gotten her to take levels. You know, Olivia, could you just take a level and let's see where it is? But I think that when they rise above 12 or 15 is when she notices and when she keeps closer. So I would hope that we could get more data, and I feel like some adults might be discouraged if I say, okay, we're going to work to get to 2 to 6. But I don't know what you guys are doing.
Thank you, Helen. Pam, Arn, would you speak to us about transitioning?
I just came up with a new transition plan. I'm going to transition all my patients to South Carolina because they have resources that we don't have in Florida. Just get them all moved. Transition is real pertinent to what I do because I work at an institution where we can't follow people past age 18. It's forbidden. Because we're a pediatric institution. So starting around 14, 15, and looking at the guidelines, I probably need to start doing it earlier. We start talking about finding an adult metabolic provider, and for us that's Helen over at University of Florida. And that has some particular challenges because we're an hour and a half away. And I think the optimal thing is for the same metabolic clinic to follow these kids for their PKU, but you know, you try to work things out. I think it's part of a bigger challenge in that population. Once they turn, I've found in my practice, once they turn that 15, 16, it's not just their PKU that is the problem. You know, it's everything. It's keeping them in the medical system at all. You know, they're not seeing their pediatrician anymore. They don't, half the time or more, they don't have a family doctor in the family. People are using the urgent care centers for all of their primary care, and it's just very difficult to talk to the family about transition of care and about staying in the system. So I think we need a better approach to that. I like the idea, and I think Hans had a slide up there about having peer-to-peer transition of care. We try to take advantage of, you heard about earlier, the Jack's Hats, the HATS program in Florida, to get them over to the adolescent care side, and then if they do have any comorbid problems, to get them to adult subspecialists. And so I think finding family, I typically try to find a family practitioner that's used to seeing kids and adults as a transition, or send them to Jack's Hats, and then try to get them over to Gainesville for the adult PKU clinic. But that is a time when we lose a lot of patients.
Thank you, Pam. So I wanted to open it up for discussion, but I'd like to actually ask the first question. Helen, one of the few health benefits of living in Louisiana is that the formula is provided for these patients. Do you think if your medical foods were provided by the state or easily available, that you might have a different perspective on how hard you push your patients?
Well, I mean, now I'm going to push my patients harder after reading the guidelines probably, but Florida does have a formulary. It's limited, but we do have a formulary. I don't know. I mean, each one is individualized. I mean, that goes back to Amy. So definitely, because we have a formulary, I'm able to get people onto diet much more easily than if I didn't have the formula.
Okay, so we'd love to have a little conversation, couple of comments, discussion about these guidelines or any problems that folks have had with their PKU patients.
Of course, woman is waiting.
Hi, I'm Effie from North Carolina. Do you actually see these patients once a month?
No.
That's what the guideline is suggesting. How feasible is that going to be?
No,
the
monitoring.
Monitor. Okay, so they go
So
to
we
get
do
their
blood-
labs done
Blood tests.
at home or in
They
the
do
lab?
finger pricks.
Oh, okay.
And it's not once a month, actually, the infants get monitored every week
Okay.
to
Okay.
heal state.
Because I was wondering how feasible that was going to be. Now,
Yeah.
when they check their levels at home, when they see you, what is the interval between visits to the center?
We talk to our patients, like in Gainesville, we talk every week, when they're
Okay.
babies. So they send diet histories, then we get blood results, then we change. So we're on the phone with these patients all the time.
There's a lot of communication that goes on other than in-clinic visits. And I would also say that there was great attention during the development of both of these papers to the realization that everybody can't do it the same way for lots of good reasons. But the attempt was to say, this is the goal, with understanding that you may need to change this in some ways based on your own practice.
And in terms of volume of patients, for a typical, like for the South Carolina clinical program, how many patients do you follow?
I think we currently have between 90 to 100 active patients, all the way up to 50.
Okay. And do you think that would be representative for most of the genetic centers with the PKU population? I don't have an idea of, in terms of numbers.
At Tulane,
what
we
that
have a
represents.
similar number.
So,
Maybe a
Depends on
little
the
larger.
size
It
of the
depends on the
state.
size of the state.
Yes.
it depends on the size of the state as well as the number of centers. In North Carolina, UNC is the only center that sees PKUs. So we probably have close to 300 PKU patients.
And so the other question I had, and I don't want to monopolize the time, is for transitioning, if you have such a narrow cohort of patients, because when I think about sickle cell disease, we have 1,000 patients in Charlotte, okay? And so it's much harder to corral 1,000 people than to corral 300 people. So how have you thought about what to do to create some sort of systematic way of teaching them those tools that we mentioned this morning for transition on
Well, now I
a
do.
regional basis
But I
even?
didn't before this morning.
Because that may be actually easier if you have distinct locations. Because sickle cell is seen all over the place. It's not just in the hematologist's office. It's in the primary care, the family medicine, and peds and adults. If they all come to you pretty much, then that actually may be a lot easier to do than what we're trying to do with sickle cell. So
I think
just a thought.
transitioning is something we all know we need to do better. We work at it, but we need to do better. And part of the problem is that you've developed such a lifelong relationship with your patients that they're reluctant to talk to anybody but you. And they also have trouble with other physicians understanding their condition.
But
And
I liked the model that they talked about this
I agree.
morning, where
Yeah.
you have the model of going, you make sure that they have a primary care physician, but you also can do the consultation. I mean, maybe eventually they'll have adult
a
nutritionists.
collaboration. Yeah.
But I like the idea that they have a home. If we can get them a home, then maybe when, like, I've lost Joey, I mean, maybe when Joey comes in with another ATV accident, the doctor would have that letter and say, oh, what are you doing about your PKU? Or are you depressed? Well, maybe you need to go back. So I've got it now. I didn't have it before this meeting, but I got it now. Yeah.
And so there's always new things that we who don't do it all the time need to be educated.
And I've talked to local pediatricians, or well, even the family practice, because we have one in Pensacola, And I said, just do a level, let's see where it is. So I've sort of, they certainly can do that, and then we can see where we are.
The difference is also that there are adult hematologists, but they're really only one cohort of metabolic geneticists, so they really aren't there adult? I see. Yeah. Same problem then, I see.
I think the MDs in this audience will appreciate that about 90% of the work for PKU patients is done by dietitians. So, you really need that support, no matter who. So.
So, as dietitians, I know you said you spend a lot of time by phone every week when the baby's born. How do you all feel about not being able to bill for your services?
Terrible.
Not good.
Terrible.
Any clinic has tried doing billing for not only the services by phone, but even seeing a dietitian, the reimbursement or code or anything, has that been looked at in any one of your clinics?
It's a terrible problem. I mean, the dietitian spends all that time and it's not billable. And worse than that is a lot of times, for some insurance companies that will remain nameless that are military, they say they have their own dietitian. And if the patient chooses to see our dietitian, that's up to them, and their dietitian's an adult dietitian who counsels people about cholesterol, so we just do it, but it really, it's a galling situation where we just have to eat it.
Well, in our case, our physicians have to be there to bill, and they have to actually go in face to face in order to bill that, but the charges are so high then. So it's a real dilemma, or there's a long wait if we put it on the physician's schedule, if they're just coming even for diet adjustments. So I was curious if other clinics have tried.
Before I retire, I hope to do something, get something.
It is something we do, which is not really billing the patient, but because we are under a state contract grant, part of our salaries are paid by the state. So we have to document or justify our services. So every time we have these kind of contacts with patients, we do log our contact, and then end of the month, I turn in my sheets to our accountant who counts my hours. And that's like, okay, she's doing the work that she's paid for. So that's at least my way of saying that, I'm doing my job.
That's similar on the South Carolina side. So we bill our activity, and I shouldn't say, but over 50% is dietitian work, just collectively overall in the treatment program. So we're able to justify the level of involvement at the dietary level.
Because if we didn't do that, then the state can come back to us and say, we paid you $800,000. You didn't use that money, so next year we are going to give you only $400,000.
I know there are other centers who are billing for non-contact hours, but I don't think they're consistently getting very much from it. I think the effort that goes into it is not worth what they get back from it.
But it's a start.
But it's a start. You're right.
Okay, so any further questions then?
Yes, I have some doubts. Hi, I'm Shirley Pardo, a geneticist from Puerto Rico, and I guess I should know this because I'm board certified, but perhaps I don't. So it's a good time to clarify. From the guidelines, I have two main doubts. First of all, normal individuals have levels less than 2 milligrams per deciliter. So why is the goal to be between 2 and 6? I mean, what if they're lower, than 2 milligrams per deciliter? Is that bad? And then the other question that I have, going back to the basic biochemical pathway, we are focusing on monitoring very, very closely the phenylalanine levels, but with all the management, the more phenylalanine we restrict from natural protein means that we are actually giving formulas. And what we're actually doing with the formulas, it's really supplementing tyrosine. That's the precursor of important neurotransmitters. So should we really be following closely the levels of tyrosine instead of phenylalanine?
Both, both.
Yeah.
I mean, but
It says
should
bo-
we
it
pay
says
more
both.
attention to the tyrosine levels in a way? I
Well,
mean, like
you should
many adults that
supplement.
are not strictly controlled, what they have is more, not cognitive problems, but more neuropsychological issues of depression, anxiety. So is it more related to neurotransmitter deficiency from lack of tyrosine and not necessarily from accumulation of
There's a
phenylalanine?
lot in the literature about that. But I supplement, if they're consistently low, I supplement, but tyrosine bounces around so much that it's a little bit
And
hard.
it's really affected by when it's taken, and there's
Food.
a lot of diurnal fluctuation in the tyrosine levels. Okay.
Yeah, I think
But you should follow
normalized tyrosine.
But you
tyrosine
should
to make
follow
sure
it.
that there's no deficiency
And
of tyrosine.
supplement if it's deficient.
And you want to do the?
Go ahead.
So the guidelines do say that if it goes to, down to 60,
Yeah.
that's okay. But, you know, when they first started to treat, there were some babies that didn't grow so well when the levels were restricted, and so I think that's what we got sort of to say that we wanted them a little bit higher. They seem to do a little bit better. But I don't get too excited if the levels are between 1 and 2.
My understanding too is that we have such better ways of monitoring now than when that 2 to 6 was first established, that the ACMG says they feel comfortable with 60 as a lower level because we're more able to monitor it carefully now than we used to.
Yeah, I looked in the literature quite deeply. I think the main ratio was when we were just using medical food for treatment, and the fluctuations were much more larger, that you could dip down way lower. And if they were consistently low, it affected the growth and also the essential amino acid needs in the brain. So that now that we have QN, and if we think that the fluctuations are going to be less, so there's a little bit more tolerance of the lower level. So the idea was, when we were just using medical food, not to go, that's why they said 2. Otherwise, the risk of going down when you're running close was much larger throughout the day.
Yeah. Okay. Well, thank you so much to all our panelists, and thanks for the discussion. Ronnie, you close the meeting.